comes, no, there are senior people like Dr. T.P. Sahu, Dr. Govind Babu, Dr. Prasad, and Amula there, because getting access to these rare mutations drugs is also a very rare phenomena. And with that note, I will start the topic. There are 15 minutes, and the bunch of rare mutation together are not rare because there are so many. So 12 years back, there was 20 years back, there was hardly anything. Do FNAC, small cell, non-small cell. Then subsequently, the histology was the issue. And that is how we evolved. And from 2000 to 2023, we have at least 50% of the lung cancer patients where we can stratify them and treat them precisely with particular therapy. And this is the graph we always show. Now, the KRAS, which is the most common and abundant mutation, also has a drug in the form of sotorasib and adagrasib. So there is a documentation that if you don't treat a targeted, the actionable mutation with a targeted drug, the survival is inferior. This is for the common mutations, and the same thing is hold true for rare mutations. So rare mutations in common drivers is the story of EGFR. We know. I will not go into the details. Apart from the exon 19 and 21, there are rare mutations in 18 and 20, and some are slightly lower sensitive, but this is what exon 20 insertion, which is I have actually encountered more frequently and the most common rare EGFR mutation. And now we have a drug, amivantamab, which targets multiple targets, including MET, and has a good intracranial activity along with lazertinib in those patients who have failed on osimertinib also. But this drug has shown an overall response rate of 40% in this particular mutation, exon 20. Find it that EGFR exon 20 is different from the HER2 exon 20 insertion. The duration of response with this drug is 11 months, and median PF is 8.3 and OS is 22.8 in this particular phase 1-2 trial. Now, these newer drugs, when we use, it is very important to know their side effects. The infusional reaction is very, very important. You need to know how to tackle this. The division of the first dose into 2 days is very important. Though I have not given this drug very frequently, we have discussed more often that if you divide the first dose, it is easier to administer and deal with the infusional reaction. Lung toxicity is very, very important. As we know, in lung, cough is the important symptoms, but you have to pay attention to the interstitial lung disease and evaluate these patients if your patient has response and then progressive cough. There are dermatological side effects. We are getting wiser with increase in use of immunotherapy. The dermatological side effects and many other side effects, you need to be looking at these side effects. So infusional related reactions, lung toxicity, and dermatological side effects, you have to look after. This is another oral TKI for this particular exon 20 insertion, which is approved in 21. Again, it is an orally available drug. Similar profile of side effects, ILD, pneumonitis, cardiac toxicity, and the GI side effects. The median duration of response with this drug is 17.5 months, and overall survival is 24 months. I am going very rapidly because there are so many mutations to cover. So this is about exon 20 insertion. Then apart from that, what we encounter together, as I said, there are many uncommon EGFR mutations like G71X, S768I. So if you look at the data of afatinib now, that is becoming more mature. There are more than 1,000 patients, including in the Boehringer Ingelheim's uncommon mutation series, and it is available on net. And the best drug, what we know from our own experience, is afatinib. That is the sole FDA-approved agent. People use osimertinib, chemotherapy with gefitinib, but the patients of uncommon mutations, which are largely included in the trial, are IPAS. Those are the gefitinib trial and Lux lung trial, which is afatinib trial. So now, precisely, there are 1,187 patients in the database. I checked yesterday. Most common mutation, what is most common is G12C. Now, what I learned is rather than going to the high index publications, you just tweet, go and check the tweet. My friend Amol is there, and the drug which is in top is sotorasib. A delta of PFS of 1 month and so many side effects. So when we see a statistically significant story, nowadays with the social media, you just search on tweet and you get a lot of information. And then we have to realize whether these drugs are really cost effective to give a benefit of delta of 1 month. There are so many side effects. And the most important side effect is financial toxicity. But having said that, this is the drug which is available to target this particular KRAS G12C. There is another drug, I will not go into the details, adagrasib. While dealing with these drugs, if your patient is on this, you have to really monitor these patients with the organ functions, the dermatological toxicity, the GI toxicity. If the toxicity happens, you have to intervene immediately, reduce the doses, interrupt the drug, so that the patient gets the maximum benefit. That is the whole idea about discussion of this. Then comes to the other rare mutations of uncommon genes, like ROS, RET, BRAF, NTRK, MET, HER2, PIK3. The list is increasing. You do the whole genomic sequencing, you get a lot of mutations. And there are fancy labs which suggest the combination of different drugs, which you will get confused and you will forget about what we have learned so far in the last 1 or 2 decades. So most important thing is ROS, which I have encountered a couple of times. This is the rearrangement you have to understand, because the point mutation happens in the point mutation also happens. So it happens in 1 to 2% of NSCLC, especially the females, younger females, light or never smokers. ROS1 gene mutation causes dysregulation and constitutive activation of the downstream pathways. Approximately 36% of the treatment patients are diagnosed with brain metastasis. The same story with other mutations like ALK and EGFR. And the drug approved are crizotinib, ceritinib, and entrectinib. So these are the response rates of 3 different TKIs with the PFS. The PFS looks promising with entrectinib. I tried getting this on the compassionate background when it was not available, and it is very difficult to write to them. It takes sometimes 3 to 4 months. By that time, these brain metastasis patients, if they don't have no feasibility to afford a drug like crizotinib, they just end up with the mortality. So there are expert people who keeps on writing for compassionate programs. So you can see those people on the Twitter also, because Twitter is very, very important. I am telling you what I have learned, and I have registered the Twitter and I learned a lot many things, especially for the rare things. So this is about the resistance mechanism. You give a TKI, you are happy, you get good responses. Within 6 months, you see that no tumor is coming back. What is beauty of lung cancer? If you encourage the patient to do either a biopsy or liquid biopsy, you end up in getting a newer mutation, and there are drugs available to target it. So in particularly for ROS, if you see the G2032 mutation is very common, and if you use a non-selective TKI like cabozantinib, the responses are excellent. So even for ROS1 NSCLC, if you treat them with crizotinib and the patient progresses and the mutation is G232, you have drugs like cabozantinib, repotrectinib, which actually encounter and overcome this resistance. If these mutations are not there, you have other drug options are available like lorlatinib, ceritinib, cabozantinib. If the progression is oligoprogression, you can use call your radiation friends, at least target that particular oligoprogression with radiation and continue the same TKI. Then comes the RET. So this is again a growth receptors, which is important for glial cell line derived neurotrophic factor receptor. Here it is important that point mutations happens in thyroid cancer, and the rearrangements are important in lung cancer. So again, the profile is young female, light smokers or non-smokers tend to show the RET positivity. And we have drugs, selpercatinib, pralsetinib, cabozantinib, vantinib, of which this selpercatinib and pralsetinib was approved in the first line with a good response rates. And again, the problem is resistance to these mutations. Whenever you get some kind of this rare mutation positive, what I do, I call the lab person and discuss in detail. I'm telling you, in the era of molecular targeted therapy, the role of genetic pathologist is very important. Just talk to them, spend time talking to them. Your life becomes easy, because you get some odd mutations which may not translate into protein which is actionable to the drug. And you give this expensive drug and you get toxicity and no effect. So a couple of times I had encountered RET, but I have discussed with the lab in lung cancer as well as pancreatic cancer. Those were the inversions which actually do not produce a protein which leads to proliferation or survival of these tumor cells. The most frequent rearrangement is with this KIF5B, which happens in 70 to 80% of the cases. And this is the most common RET mutation. And there are other partners. That is why I said you have to talk to your pathologist, genetic lab person. So this drug, selpercatinib and platinum, with the good responses of 60% and 80%, PFS of 24 months and 22 months in platinum treated as well as new patients. And for the other drug, pralsetinib, it is median PFS of 17 months, in platinum doublets, and neo patient, because these are small number of patients, this is 9 months. Both the drugs are approved drugs. As I said, for other drugs, it is very important to monitor the toxicity. Blood pressure monitoring is very, very important for both the drugs. Monitor the labs very frequently in the beginning, especially the liver function test. See the patients developing edema. These, if you monitor the patients and see clinically, you end up in seeing this toxicity more often. It is very, very important to look at the ECG and discuss with the cardiologist, because sometimes the machine doesn't give the exact QT interval. And see that no, these patients end up in getting arrhythmias and sudden deaths, which actually attributed to the disease. And you end up, if you do this, see these patients, these are responding patients. So looking at the ECG is very, very important. For a medical oncologist to keep the physician inside them alive is very important in the era of immunotherapy and targeted therapy. Then the most common mutation, which is in melanoma, is BRAF, which we see less often in lung cancer. The story started with the BRAF targeting monotherapy, which the investigators failed. Then they failed that if we target BRAF as well as the downstream signaling, the combination is synergistic, it delays the resistance as well as it inhibits the growth of the cancer cells more effectively. So the drug is DCJ approved in India, dabrafenib with trametinib combination in BRAF positive. These are the commoner V600E mutations, and there are other mutations also. Again, if you give BRAF mutation, don't talk to the lab people whether they are relevant or not, because you get so many missense mutations which are not actionable. So this is with the monotherapy and doublet in treated and untreated patients. Definitely the combination is better than the monotherapy. Then going ahead with a very rare mutation, NTRK. The responses are best with this targeted therapy, but these are very rare mutations. They are seen in various malignancies, right from the brain tumors, thyroid, gliomas, skin tumors. In lung cancer, the incidence is less than 1%. Again, for NTRK genes, fusions are activating and predictive of response, not the mutation. So if you get NTRK, please do discuss whether that is actionable or not. The fusion leads to overexpression and constitutive activation of kinase domain. You have incidence is 0.21% across 11,000 patients with various different tumor types. So you see the responses, two drugs, entrectinib and larotrectinib, responses 63%, 83%, and the PFS and OS data looks better. Even with larotrectinib, the median OS is 40%. What is important? The methodology which we use for diagnosing these mutations. 10 years before, we hardly used to get these mutations. Now we have good labs in India itself. We see these rare mutations now commonly. If you process the tissue, even there are no smaller assays, lung-based panels, which can pick up some of these mutations. If you go with the broader panels, the chances become slightly better. So before sending your sample, you have to at least talk to the laboratories what are probabilities of getting these mutations. 1 minute, I'll finish that in 2.5 minutes. So maybe I was too fast. So these are the two drugs approved for NTRK. And what is more important, if you see the toxicities, the fatigue, the constipation, GI side effects, cognitive impairment. I started using lorlatinib and then I realized this simple side effects which we see with immunotherapy, paclitaxel neuropathy is very common with drug like lorlatinib. So you have to ask the patient with the questionnaire. Cognitive side effects are very important. Patient comes with the cognitive decline. Patient comes with the hallucinations. You have to pay attention to all these side effects. The most important thing, not only for these two drugs, for other drugs, is drug-drug interactions. We have to understand our patients are elderly patients. They are all on polypharmacy. And if these patients on inducers or inhibitors of CYP3/4A, which is the most common liver enzyme, then we might encounter decreased efficacy or increased toxicity. So we have nowadays instrument to check the drug-drug interactions. It becomes very easy, even though your OPD is busy. But do pay attention to what drugs the patient is on. Pay attention to the toxicity like congestive heart failure, CNF. Some drugs leads to increased risk of fracture, hepatotoxicity, hyperuricemia, QT interval prolongation. Most of these TKIs leads to QT prolongation. If you intervene and look at the electrolytes, that becomes very important. Sometimes they do cause a decrease in various kinds of electrolytes. Bone marrow suppression is also some of the, in the form of anemia, neutropenia, is side effect for larotrectinib. So looking at the laboratory parameters very carefully, even though these drugs are oral drugs, because no, some of our colleagues feel that no, oral drugs are very safe, but they are not. You have to pay attention to the toxicity. So this is about entrectinib and larotrectinib. Then another rare mutation is c-MET mutation. In lung cancer, this happens with older age females, smokers as well as non-smokers, adenocarcinoma, and sometimes chromoid histology. So basically, there are two drugs which are approved, capmatinib and tepotinib. Look at the response rates, 44% and 66% platinum treated patients and new patients. And there are two cohorts for tepotinib, more or less 40 to 50% response rate, or 50 to 60% in new patients. And good PFS with both the drugs. Both the drugs are approved in MET exon 14 skip mutation with the phase 2 trials. Again, you have to monitor the liver toxicity, and lung toxicity is important while these patients on capmatinib as well as tepotinib, and drug-drug interaction is very, very important for these oral TKIs. So monitor liver toxicity. Phototoxicity is very important if the patient, as we know from the Jeftinib and Arlotinib story, you have to put the patient on sunscreens and monitor this skin toxicity also. And the last mutation I will discuss is HER2 mutations. As we know, breast cancer, when 10 years back, I used to feel that trastuzumab has changed the fate of breast cancer. Someday, we should get such drugs in lung cancer also. Here, the amplification is not important. The mutation is important here. And the most common is again a kind of exon 20 insertion type of mutation, which now can be detected with the broader panels. And the drug, which is trastuzumab deruxtecan, very fancy drug, and don't ask me the cost. And I have counseled my breast cancer patients, hardly any patients. So 99% of the patients can't have access if they have to pay from their pocket. Very expensive drug, but this drug ultimately has showed good responses in this subset of patient. Trastuzumab deruxtecan pre-treated HER2 mutated metastatic NSCLC. I think last ESMO only that this data was published, right? Yeah. So last is also here. So good responses. If you see the disease control rate, I will not quote the overall response. The disease control rate 92%, median duration of response 9 months, and PFS is 8.2 months. This is pre-treated patients. Again, so this is a monoclonal antibody where no payload is linked with a linker to the HER2 targeted monoclonal antibody, which may change the fate of this subset of patient, rare mutation, in the future if the cost comes down. And I'm seeing that the cost was above 10 lakh, and now it is somewhere below 10 lakh for one dose for this subset of patient, and the drug is yet not available in India. Most of these drugs are not available in India. If the mutations comes positive, there are good friends which you can search actually again on Twitter. They will tell you how to write for the compassionate. I usually call Akhil and Vikas, and I think they have succeeded in their efforts to get again Ullas. They know how to access these mutations, drugs for these mutations compassionate. Yes, there are trials. No, I'm saying trials we will definitely send to you. Again, one more thing, there is a clinical trial group also on the WhatsApp. Those who are interested, we can join. And if any of the mutation comes, you have to discuss with these guys who have the trials as well as with the laboratory person. These two most important things, has actually, made our life easier. We just call Ullas for the trial, and there are a couple of patients. And if you don't know anyone, you can call Amol. He knows, because if you see recently, he is a